My background is in academic. In particular, I've done a lot of work around simulation-based team training, which is where this work came from, and it was also been very done a little bit of that simulation work with Ravi. So this talk is based on this paper that we wrote for the BJA. It was actually part of the BJA centenary. So it's called Teamwork Matters, Team Situational Awareness to Build High-Performing Healthcare Teams. And it was a narrative review. And so I'll basically walk through this this paper, and you can then ask questions afterwards. So just taking a step back, looking at the evidence on teamwork, I think we have a lot of evidence now that teamwork does matter, and it does save lives. And we've got increasing amounts of evidence building through systematic reviews in ED and in measuring reasonably high quality patient outcomes, and some associations with the staff perceptions of how team works with patient safety outcomes, and also some evidence growing of a lower odds of 30-day mortality or failure to rescue with places where there's better teamwork. So interesting, and something I don't think we can avoid. And there's been a few meta-analyses now, so this is really starting to produce good evidence. So it's one by Hughes and one by Schmutz. And this one from Schmutz, he calculated, I think it's a he, calculated that teams with effective teamwork processes were 2.8 times more likely than others to demonstrate better measures of patient outcomes. And these outcomes across these studies included mortality, morbidity, or measures closely related to patient outcomes, which are things like adherence to treatment guidelines. So I think where we're heading now is this acceptance that you probably don't need to keep trying to prove that teamwork or simulation-based team training is something we need to do. We just need to get on and do it more effectively or effectively. I think we've been going on about teamwork for quite a few decades now. And this is a report coming out of the Joint Commission. This is the 2022 report. You might remember there was these have been going on for several decades. And failures in teamwork and communication continue. And the causes for those failures are still around not establishing a shared understanding or a mental model across care or across team members, and no or inadequate staff-to-staff communication of critical information. So I'd put it to you that whatever we're doing has possibly, well, I'd hope it would be making a difference, but I don't think we're there yet. And this is just, I guess, another way that we could potentially look at it, which is what Ravi and Craig and I proposed in this paper, looking at team performance through the lens of situation awareness. And I think this could be another angle to get hold of this problem, because I think it is aligned more with the way that clinicians diagnose and treat. So it's having situational awareness is not what you might call a soft skill. And I think sometimes we've been a bit too we've been sort of thinking about teamwork and communication as non-technical or soft skills, or I guess things that are more about the way we feel and the way we behave. But I think situational awareness is quite clearly defined, and it's got a sound theoretical basis in cognitive psychology and human error. It's measurable, and it has been measured. And I think it's achievable through specific actions rather than just by trying harder or perhaps trying better to better at communication. I mean, often we hear at the end of simulation training that, you know, the take-home message is, I'm going to communicate better. And I think that's really probably a bit vague to actually make a actual difference to the way you work in your teams. So situational awareness, just going back to the basics, which I'm sure you'll all have heard of. So it's about perceiving the cues in the environment. So there's sensory input, and it's about that perception of it, and it's about understanding what that means. So what does that blood pressure mean? What does that particular clinical sign mean? And then about predicting what's going to happen next. And it came, I guess it came initially from the aviation, which has contributed a lot to our team training and in medicine, and particularly in anaesthesia. It's about this fighter pilot actually first seeing the planes, then understanding what sort of planes they are, and then predicting what they're going to do next. And you can see that might be quite a life-saving skill. This is, I guess, this is us. This is us in the theatre, and it sometimes does look like this. And you can see that there's a lot of stuff going on. So there's so many things going in into your, you know, the bit where your sensory input. There's too much really going in for you to take that all on board, and so you can't pay attention to everything that's there. And in order to get the sensory input into your working memory to work out what the problem is, you need to be able to pay attention to it. But I think in the situation we sometimes have cognitive overload, and we just can't. No one person can take all that information, and so things get missed. I like meerkats, but I did try when we first submitted our article to the BJA to include this picture, this AI generated picture of meerkats, but it was considered too frivolous. But I think it's quite good example of the idea of perception and of a team perceiving and taking notes. So combining the cognitive capacity of the whole team, it makes it much more likely that you're going to be able to maintain situational awareness beyond the capacity of any one person. So it's involved in monitoring the patient. It's involved, you need to be aware of what the team actions are, what everybody's doing, monitoring the environment, what's changing, you know, what's the situation outside the room, who's in the room where the equipment is something missing. And it's managing the sharing of information, and it's also allowing people to raise questions and consider, you know, we've made this plan, is it the right plan? So moving from that idea that one person has to hold all that stuff in their head to the team contributing to a team situational awareness in an operating theatre team. So team situational awareness would mean that every team member understands the situation, is actively engaged with patient care, and there are no barriers to speaking up with information or questioning plans or suggesting options. That sounds like a good plan, but what we really require for that to happen is we need psychological safety, and we need to have a shared mental model to start with. This is might have read the work from Amy Edmondson on psychological safety, and it's basically a belief that you won't be punished or humiliated for speaking up with your ideas, questions, or concerns or mistakes, and it's safe to take interpersonal risks within your team to make challenges, for example. So I think a lot of we've all recognised this, the importance of speaking up with information, and it's not. But it's not easy. All of the, I don't know about UK, but in New Zealand, there's been quite a few campaigns to basically get nurses to speak up. And it may have worked a bit, but we think it would be much more effective if we took this speaking up for patient safety and flipped it on its head, which we did in a published qualitative study looking at what it's like to be spoken up to, really. So understanding how it feels for the senior leaders to be spoken up to by their team, what sort of reactions they have, and how that subsequently affects how the team performs in the way they respond. And from that work, we developed this reflective questionnaire. So it's basically something that you would fill in these, you would answer these questions and think about your own reaction to these situations. And it seems to have generated we've tried it out in about 50 people, and it seems to generate quite good reflection on your reactions, and then starting to try and understand why you react like that and how that might be perceived. I guess the take-homes from these questions are about acknowledging that there is a hierarchy, and we might find it easy to speak up, but not everybody does. In fact, most people don't find it easy to speak up against that hierarchy for a number of reasons. It's also about admitting vulnerability, say admitting when you've made a mistake. One of those questions was admitting errors publicly could undermine my reputation, and I guess the discussion around those points is more like people are much more likely to respect you if you admit your errors. So admitting the vulnerability and accepting challenges from other people, and addressing bias, admitting that or recognizing that you will have bias. So some of our an example of that would be some of our participants in our qualitative study said that they were more likely to listen to somebody they knew, a trusted colleague, than somebody else, whereas that somebody else, be they a nurse they'd never seen before, or possibly even the healthcare assistant, they might have one vital piece of information that needs to be listened to. And so it's addressing that bias against the implicit bias we have against all sorts of different situations, different relationships that might influence how much we listen to the information. And the other thing that it brings out is that there are cultural differences in the way people view hierarchy and also speak. Some people are much more direct in the way they think. New Zealanders tend to beat around the bush and hint and hope more, I think. So somebody coming directly might be a bit affronting. So accounting for those cultural differences and making allowances. So one of the styles of leadership that you've probably heard about that would incorporate these characteristics that we're trying to promote with leaders is this idea of inclusive leadership behaviours, where you're actively eliciting information from your team. You're inviting them to participate actively, not just thinking that you invite. You have to actually say it, because some people won't make those assumptions. When somebody provides an opinion, you acknowledge it, and if their opinion is valid, you're prepared to use the contributions from the team to solve the problem. So it's actually not just acknowledging the information, but also demonstrating that it's a joint decision that you're making. And so that sort of way of responding that encourages further contributions, and the leader motivates team members through encouraging them to feel engaged and connected to the group. So those are inclusive leadership behaviours. I think they've been aligned more with women than men, but something I think is increasingly becoming recognised as important for patient safety, as opposed to the authoritative leader behaviours, which I won't read out. But basically, I think that the attributes that inclusive leadership requires is humility. So you're not the sort of the champion leader on the white horse that's going to save the day. You're a humble member of the team that needs other people in the team to help solve the problem. You've got empathy with the other members in the team, understanding how difficult it is for some to speak up. You admit your vulnerability, and you are resilient, which I guess has got a number of elements to it, in that you at least partly need to be resilient to that idea of being challenged and having to accept questions from your team. So this is another other idea from Amy Edmondson. So we've talked a lot about psychological safety there. So you can have a very safe team. So you know everybody can be feeling extremely comfortable and having a nice time, but unless they're engaged, unless they're motivated and engaged with the work of the team, basically nothing's going to happen. And so you can also have a team that's very engaged and invested in a good outcome, but it doesn't feel safe to speak up, and that leads to a lot of stress. So it's finding that line where the team feels both safe to speak up and engaged with the patient care. So we're going back to the basic requirements. I just talked about psychological safety, and I just want to touch on shared mental model. So these are the ways that we go about sharing the mental model. If people don't understand what the plan is, or what the situation is, they're really on the back foot in terms of being able to contribute. So I think starting right at the beginning of the day with or the case, with briefings about what the plan is for the surgery, plan for the anaesthetic, any nursing or tech issues, and also importantly getting to having a bit of a briefing about who's on the team, what their names are, which is incredibly important, knowing people's names, and also what their roles are. And is this their first day in theatre? Are they actually going to, if you send them off for something, are they going to know where it is? So it's gauging what team you've got on the day, and starting to build a bit of a relationship. And then we've got all these other tools that are useful for maintaining that shared mental model, and it's things like the surgical safety checklist, structured handovers such as ISBAR, recaps of the situation, so updates when something's changed or where you don't know actually what's going on, and you need to take a pause, or where you've sort of got to a situation where things aren't improving and you just need to stop and take stock, or when new people come in. So recaps. It's something that seems to happen quite a lot. I've noticed in the emergency department, they're very good at doing those structured recaps, but it doesn't seem to have been quite such a culture in the operating theatre to recap on where we are with the team. Using sort of communication that actually works. So it's communication where you're actually directing it to somebody, and you're looking for, you're looking to see that it's actually been done and the results come back to you. So things like use of whiteboards, allocating a scribe, and multiple other ways that people have devised for sharing that information, sharing that mental model. And part of that is to keep your situational awareness up. I guess I think these are sort of things that we often talk about, especially in simulation, in the situation of a crisis. And so we practice anaphylaxis or massive hemorrhage and stuff, and everybody's engaged that. But I think a lot of the adverse events that we see in our hospitals and on our health and disability commissioner reports are around things where there's a bit of a slower, things are gradually deteriorating over time. And I think that's a bit of a problem in New Zealand around the deteriorating patient on the ward, where they're monitored and monitored and monitored as things gradually change, but nobody steps up. Nobody says, "Hey, we need to take another look." So it's this slow burn, and which can be during an anaesthetic if something's happening gradually. I've got frogs there because you've probably heard of the boiling frog metaphor, where if things happen slowly, you don't get a reaction. Whereas if somebody then came into the room and saw what was happening, they'd say, well, so it's about complacency, I guess. Sometimes it's about being really familiar with your team even and not being challenged. Maybe you've got a plan that you've already agreed on, and maybe you just look for information that confirms that your plan is a good one, and also fatigue. So that sort of gets to the situation where you've over time gradually lost awareness of how the situation is deteriorating. So you can think up countermeasures for this. I mean, be an engaged team, I guess it's eternal vigilance, commitment to patient safety, remaining curious. I think as diagnosticians, it's that sort of, this is probably what it is, but what else could it be? It's continually looking for those options, looking for deviations from where things aren't going towards in the direction you expected, and questioning that dissonance rather than maybe just trying to confirm the evidence that supports your original plan, and just challenging those assumptions. I think that sounds really hard, and perhaps it would be extremely fatiguing to have to do that all of the time. And I guess that's why things continue to sort of go wrong in a way, because sometimes I think we're being asked to do things that are beyond human capacity. So I think one of the approaches that might be helpful for us in the future is to do with systems redesign to maintain our situational awareness. So in anaesthesia, we do have a lot of single sensor, single indicator monitoring. It may be better in your theatre, but we would have in our theatre, there'd be 3 places that you could see the ECG. You'd have to look somewhere else for the volatile, somewhere else for the nerve conduction monitor. So the information is all over the place. And so it's a cognitive burden of just finding it and then synthesizing it and interpreting the individual data elements. So there's some new monitors coming out that might be better at synthesizing that. And I quite like this monitor that's, I think, now available, where you've got a bit of a body that will give you an overall picture of what's going on, whether they're actually, their heart's still beating at a good rate, their blood pressure's okay. So the idea of sort of an integrated visual that we can rapidly look at and get an overall picture, sort of way of somebody else synthesizing all that data. And then I think there's some scope for looking at how artificial intelligence may help assist us in maintaining our situational awareness. It doesn't get fatigued or distracted. I mean, it does sometimes hallucinate, but I think we need to work out how to get around that. We still need a human in the room. But it's good at recognizing patterns in large amounts of data. So it could learn to keep collecting the data and noticing when there's a small deviation and alarming. So I'm thinking particularly of the slow burn loss of situational awareness, where there could be another trigger to take another look. It's good at taking some of your cognitive load off you. Or you can do this already through calculation of drug doses or checks for allergies or interactions with drugs. We can already, and it just starting out monitor data integration. So I think that's something that's happening already, and algorithms to streamline alarms. But I think in the future, it's likely to be able to provide assistance in clinical decision making. So putting together a whole lot of information and recognizing patterns and being able to offer some options. So I think these are probably my summary points. So we've studied teamwork a lot, but it's still a problem. So we think potentially taking a new look in our interventions around and looking at focusing on optimizing situational awareness. Maybe another way of approaching team performance, and exploring team situational awareness, and measuring it, and strategies to optimize it could provide us with new insights into team performance and better ways of training. So that's it.